Endocrine neoplasia, MEN syndrome, refers to a group of rare genetic disorders that cause tumors to develop in multiple endocrine glands and sometimes other tissues. These syndromes are inherited in an autosomal dominant pattern, meaning a single copy of the mutated gene from either parent can cause the disorder. MEN syndromes are categorized into three main types: MEN1, MEN2, subtypes 2A and 2B, and MEN4. Here is an overview of each type. MEN1, Wermer syndrome. Gene involved: mutations in the MEN1 gene, which codes for a tumor suppressor protein called menin. Affected glands: parathyroid glands. Hyperparathyroidism is the most common manifestation, often causing hypercalcemia. Pituitary gland: tumors such as prolactinomas or growth hormone secreting adenomas. Pancreatic islets, gastrinomas causing Zollinger-Ellison syndrome, insulinomas, and other neuroendocrine tumors. Other associations: adrenal tumors, non-functional or rarely secreting hormones. Carcinoid tumors, skin lesions like angiofibromas and collagenomas. Symptoms: symptoms vary but may include kidney stones, peptic ulcers, hypoglycemia, and headaches depending on the affected glands. MEN2 is caused by mutations in the RET proto-oncogene and is further divided into two subtypes: affected glands. Thyroid gland. Medullary thyroid carcinoma, MTC, is a hallmark, often developing in childhood. Parathyroid glands. Hyperparathyroidism occurs in a subset of patients. Adrenal glands. Pheochromocytomas, tumors producing excess catecholamines. Symptoms: symptoms are related to hormonal overproduction, e.g., hypertension, diarrhea, and tumor growth. Distinct features: early and aggressive medullary thyroid carcinoma, pheochromocytomas, mucosal neuromas, benign growths on lips, tongue, and other mucosal surfaces, marfanoid habitus, tall, slender build with long limbs. Symptoms: along with MEN2A features, patients may have gastrointestinal issues or physical signs of marfanoid body habitus. HAP-MEN4, gene involved, mutations in the CDKN1B gene, which encodes a protein involved in cell cycle regulation. Affected glands: parathyroid glands, hyperparathyroidism, pituitary gland, adenomas, rare neuroendocrine tumors in other locations. Symptoms: similar to MEN1, but less well defined due to its rarity. Diagnosis: 1. Genetic testing, identification of mutations in MEN1, RET, or CDKN1B genes. 2. Imaging, MRI, CT, or ultrasound to identify tumors. 3. Biochemical testing, hormone level assessments, e.g., calcium, gastrin, catecholamines. Treatment: 1. Surgical management, removal of affected glands, e.g., thyroidectomy for MTC, parathyroidectomy for hyperparathyroidism. 2. Medical management, hormonal therapy to control symptoms, e.g., proton pump inhibitors for gastrinomas, medications for pituitary adenomas. 3. Targeted therapy, kinase inhibitors for RET mutations in MEN2. 4. Surveillance, lifelong monitoring for tumor recurrence or metastasis. Prognosis: prognosis depends on tumor type and timely intervention. Hypercalcemia and pancreatic tumors are major concerns. 2. Early diagnosis and prophylactic thyroidectomy in at-risk individuals can improve survival, especially for MTC. Prognosis is less understood due to its rarity. Early genetic counseling and testing are crucial for affected individuals and their families, as early interventions can significantly impact outcomes.